3, which was June. I think that was an error. We have communicated with them to clarify that. Yes. How do I go back? Sorry. And then you can also see in Chile and South Africa, testing was kind of steady in Chile, whereas South Africa, it kind of dropped off early on, but it went back up. But the 2020 positivity for influenza was very low in both countries. And this is just showing in all the reporting Southern Hemisphere countries that influenza really dropped off. This is around March, and then May was here, and nothing since then. And in the Northern Hemisphere, a similar event has occurred. So their winter season would be around here, which has showed no influenza. And this is a CDC, US CDC outpatient ILI surveillance network graph. So this is so this should say September 2020 to March 21. So you can see that activity has been very low for this year's flu season compared to the previous years. Back to WA, we can see that respiratory attendance. This is to all ED departments. This is usually the winter flu period. Excuse me. Sorry. So this was 2019, which saw a big peak around June. And then last year there wasn't a peak at all, but presentations to ED started increasing around November, December. And then if we look at non-influenza respiratory viruses detected at Path West, you can see in the red line, which was last year, there was a really big increase starting to occur in November. I'm not sure if that coincided with the WA controlled state border opening or what the reason was. And this was also seen in other states around Australia too. So that increase was actually due mainly to RSV, which is seen in the blue here, and then the other non-influenza respiratory viruses contributing just a small amount there. So we're wondering what that caused that increase, and I think a lot of people are still a bit puzzled as to why that may have occurred. It could have been possible maybe intrastate travel increased, the interstate travel increased as well. Maybe due to not having the flu season, there was a bigger naive population. Younger children weren't exposed to the normal winter respiratory viruses, and then it just kicked off here. We're not exactly sure. It was also noted that the median age last year was higher, 18 months compared to 7 to 13 months in the previous few years. So will there also be a similar rebound activity for influenza? We're not exactly sure when it will happen, but we're pretty sure that it will happen, and that there will be a larger naive population as well. So it will be increasingly important for everybody to get the influenza vaccines every year. And acknowledgements, thanks for everyone who helped with the presentation.
Sarah, I've got a question for you.
Sure.
When the Australian borders finally open, will we see a particularly hard flu season because we have had so little flu circulating in our population for over a year?
Yeah, so that could be true. As we normally get, the Northern Hemisphere flu season, then those strains then kind of come into the Southern Hemisphere and we share ours back and vice versa. So closing of that international border and then overseas arrivals having to do their 14-day quarantine in hotels has really stopped that transmission out into the community in WA and around Australia, and I'm guessing around the other parts of the world as well.
So you reading them?
Yeah.
So yeah, that might actually occur, and so it would be really important to get our flu vaccines.
So just have one more question
Sure.
from Michelle and Louise. We are also testing more when our residents have ILI. With this may be why we are detecting more RSVs. That's probably more a comment than a...
Thanks, Penny.
Yeah, thank you.
Thanks, Sarah.
Right.
Thanks very much. Right, we're just going to keep going on to the program overview. So I just wanted to rehash, for those of you who are very familiar with running an influenza immunization program, you'd have your toolkit hopefully well and truly set and ready to go for 2021. But I'm just going to cover these points to make sure we've got all our checklists sorted and ready. So the ATAGI statement, as you are aware, comes out each year around the administration of the flu vaccines, and it's no different for this year. We've seen very little difference, and in fact, no difference in the groups that are eligible to receive the vaccine. There's only one very minor difference in the eligibility for the vaccine, but I'll leave that for Darren to cover in his talk, which is just after mine. So there's also some Commonwealth material that will be making itself available. So I just want you to be aware that what you see on the screen is not the 2021 resources. They're not yet available on the Commonwealth website, but they won't look too different to what we've seen in previous years, which is what's on the screen. And that's where you can find your Commonwealth resources. So that's the health.gov.au website. Now, looking at the state program, for those again who are familiar with influenza in WA and running the program, hopefully you're quite familiar with receiving this letter from the WA Health Department each year. This letter is emailed out through Vaccine Updates, which is our email subscription service that I'll cover later on in the session. And it just essentially captures the key points around the program, eligibility criteria, vaccine ordering instructions, etc. The immunization schedule has been updated with the 2021 vaccines. And as I said, there's no difference in the brands of vaccines available this year as opposed to last. We have also updated the immunization pages on our website for influenza. So everything that you see on there is relating to the 2021, as is the the immunization update, immunization influenza update. Online module has also been updated and is ready. These are our collateral or our posters that will be available this year. That's from the WA Health Department. And this was similar to what was our campaign that we started last year. So as those of you who are aware, we had a free influenza program for WA primary school age children, which will continue this year. So I mentioned, other than the addition of the primary school category, there isn't a difference in our eligible groups for this year. So you've got pregnant women. It's particularly important that they receive the influenza vaccine. Those with underlying medical conditions, all our children from 6 months to less than 5, all our Aboriginal individuals from 6 months to whole of life, and non-Aboriginal individuals over 65. As I mentioned in my previously, that will be providing a lot of information for the influenza as well as any other NIP immunization program. All updates will be provided through Vaccine Updates. That's the quickest and the best way for us to get in touch with you quickly. So if you'd like to subscribe, I encourage you to go to this website and you'll see it on our influenza pages, the option to subscribe to Vaccine Updates. Just while I'm on this slide, I just wanted to quickly also mention a second vaccine update that we've stood up that's particular to COVID. So this one is Vaccine Updates, which is the general vaccine updates. And we've had one that is called COVID Vaccine Updates, and that's specific to COVID. The reason we did that, that's got a bit more of a green background to it as opposed to this blue one. So hopefully you can see the difference between them. The reason we've done that is because as we share COVID specific information, we just wanted it to be quite obvious to our providers, the content that they're receiving it, that it's different content. Sorry, that's a question?
Yeah, we do have a question from the Rosewood boardroom.
Because that's me done.
Yeah. We would like to book in our staff flu vaccination clinic, but can't because we don't know when staff are scheduled to receive the COVID vaccine.
Right, so that's a good point that you've raised around receiving the influenza and the COVID vaccine. So as you may know, there's an ATAGI statement out around that specifically, and that's a 2-week gap that you'd want to have between your influenza and your COVID vaccine. With regards to when staff can access their COVID vaccine, that program's being currently rolled out. So unfortunately, I don't have specific dates on when you particularly can get the COVID vaccine, but you'll be provided some communications with regards to that very shortly. One more question, Penny? That's all we had. Fantastic. Thank you very much.
Thanks, Pam.
I'm just going to introduce our next speaker, Darren Westfall. Darren is the program officer who leads the vaccine management team within the immunization program, and he'll give us an overview of the vaccine brands available. Sorry, Darren, if you just use that right, and yeah, right click and go to the next slide.
All right. Great. Well, thank you, everyone. This is a very different way of doing things, but the world has changed. It seems like it wasn't that long ago that we were doing this a year ago. Feels so much less than a year, but here we go. With the 2020 influenza program, I'll talk just a little bit about the vaccine and how it's going to be distributed. Just some general information. First of all, and I think most importantly, if you have any 2020 influenza vaccine in your fridge, discard that straight away to avoid giving the wrong vaccine as the 2021 formulation will be arriving soon. Vaccine orders are placed through the online ordering system, and order confirmations are sent to the account email. The system is regularly updated throughout the season, so any new information or changes will be available there. So it's really the first point of call to get information. Distribution will commence for the over 65s from today. Distribution for other cohorts will commence when the vaccine becomes available, and that's really expected to be the middle of April. And even later for the primary school program. And that's just because it's taken a bit longer to get things in country than it did last year. And also with Securus working on the COVID vaccine, there has been a delay with the Afluria quad. Remember to report all wastage and incidents through the WA Health cold chain breach and wastage reporting process. So just in terms of a timeline of when you can expect things to arrive, when we're expecting things to begin. So today, again, for the Fluad quad for the over 65s, and then the week of the 12th of April for the pediatric and the 5 to 65 medically at risk. And then the primary school program a week later, the 19th of April, and then the WA Health staff healthcare worker program will start after that. And you'll see just at the bottom of the slide, there's a pre-allocation process that we're using this year with GPs. I think I might have some information about that coming up, but the table that you'll be familiar with. And after this meeting today, we will send out a flu update that does have all of this information in it for you. So these are the products that we're using this year. VaxiGrip Tetra, we used that for the first time last year, and that's for the 6 months to under 5 years. All primary school-age children will be using Flu Quadri this year as we used last year. And then there's 3 different vaccines available for the medically at-risk group of 5 to under 65. So Fluria Quad, Flurix Tetra, and VaxiGrip Tetra. Again, all products that you've used before. And Fluad Quad, again, this year for the over 65s. So a bit more on that pre-allocation process. So last year, we we kind of we had plenty of vaccine for everyone, but ran into a bit of trouble with, with the vaccine going out probably in not all of the right places. So we've worked really hard kind of between last year and this year with the RACGP and with WAFA to come up with some ways to really improve how we distribute the vaccine and make sure that everyone who needs it can get some. And so we have a pre-allocation model that we agreed to for initial distribution this year. So for the first 6 weeks, we've used the data that we have, the data that WAFA have for population and data with practices, and we have pre-allocated doses of vaccine for for general practice. General practitioners have had an opportunity to review those and to make comments, and hopefully there was a bit of of fixing it and getting it right, and so for the first 3 deliveries, they will have that all pre-allocated. The really great thing about that is that they'll know exactly how many they're going to get each week, each fortnight, and they'll be able to plan. Accordingly. GPs will be able to order more vaccine after the initial distribution period through the usual process on the WA Health online ordering system. Just some reminders: poisons permit or APRA registration details must be current in order to receive vaccines. So just double check that. At the end of June is a typical kind of expiration period, although that's changing. So it's just really important that you double check that so that there are no delays. Go to the ordering system for more information about the program. Now, of course, we also need to spend a bit of time talking about wastage. We know that we do waste a lot of influenza vaccines each year because the vaccines are only good for 1 season. And we get enough in probably for the whole cohort. But last year, a lot of vaccines were wasted primarily in general practice, but it's general practitioners that are doing most of the vaccines, most of the vaccine administrations. So that's not surprising. Ooh, back and on. Are there any questions?
Yes, I do have some questions.
Excellent.
For you.
Oh, excellent.
Actually, there was the question. There was a question around whether the event is being recorded, and yes, for those people that joined a little late, this event is being recorded. Darren, the only one that came in after Pally's session was around when will the cutoff be for residential aged care workers and visitors need to be immunised for flu? This is difficult this year due to COVID vaccine schedules.
That's a good question. I assume this is about the directions, so the aged care directions number 4, which haven't, which there hasn't been any change other than in the directions it does state that as the vaccine is available, or it's as long as the flu vaccine is available, it's not quite available yet. I know that some pharmacies may have some private vaccine. I'm not sure about general practitioners, but it's a good point. I don't know if anyone else in the room has any comments about that, the aged care directions and needing to be vaccinated with flu to visit an aged care facility.
I think they still stand.
Yeah,
They do. Yeah, they do still stand. I guess the question was that it could be a little bit tricky this year with the.
in the directions they've clarified, but there's no date yet.
There's no end date. Yeah,
No,
so it's always been current, but with COVID vaccine, you have to there's timing kind of things in between doses, and you might not be able to get your flu vaccine until later. That might be the comment. Yeah, sorry, I don't have any information about that other than we do know that those directions are still in place.
Thanks, Darren.
Great.
That's it.
Thank you very much.
Excellent. So we've got our next speaker, Dale Caccioni. Dale is an epidemiologist in the Immunisation Program, and she's going to give us an air update.
Thanks, Callie, and hopefully everyone can hear me okay. Please let me know if there's any problems. I'll also ask someone in the room if they could move the slides along, please. Thank you. So today, most of my talk will probably be information that you're already aware of regarding PRODA, but one new piece of information that's come in more recently is the mandatory reporting to air. So there was a bill passed in February this year that said that the reporting of immunisations to air would be mandatory, and they were going to roll this out in a phased approach, starting with COVID-19 vaccinations and influenza vaccinations from the 1st of March. There are some fines for those who aren't complying with this process, but we will have to refer to the air to see how they go with reviewing those and seeing how people comply. And after the 1st of July 2021, all National Immunisation Program vaccinations will need to be reported to the air. So that's a new piece of information that's come in more recently. Next slide, please. So just quickly touching on PRODA, and for many of you, this will already be information you know, but for those who aren't familiar with PRODA, I'll just quickly go over the process. Historically, the access to the air has been through what's called an authentication file. That's going to end as of the 30th of June this year. It was extended from last year's deadline to this year, but I don't see any extensions occurring past this date. So we do need to move to the new PRODA online system. Next slide, please. So the benefits of PRODA, according to the AIR, are that it has greater security than the current authentication file system. It's quick and easy to register online. You can access the AIR from any device, and there's the ability to send attachments to the AIR with their secure email from HPOS. Next slide, please. So for those who haven't already set up the system, or for those who have, you might be familiar with the mechanism. There's two parts to it. An organisation needs to set up their PRODA access, and then individuals within that organisation also need to register with PRODA and get an individual PRODA account. What I have recommended for our larger health service provider organisations is to have a representative, a PRODA representative, who can assist individuals with organising their individual account and organise the organisation account. And that could be said for GP practices and others out there who would be good to have one person or several people, but someone they could contact to assist them and add members, etc. Next slide, please. Okay, so individuals, if you need access to the AIR, then you will need to register with PRODA, and you'll be assigned what's called an RA number, and that will be used to register you with the organisation's account and add you as a member, and then you will be able to access PRODA every time you log on as an individual and access the AIR through PRODA. Sorry, yep, next slide. Did we go 2 slides? That's okay. Sub-organisations, thank you. So for those in a health service provider or an area health service, only the single organisation with the single ABN can register as an organisation. And then underneath that, all the different AIR provider accounts will be organised as a sub-organisation. And there can be many sub-organisations under the one organisation, and these can have, each one will have a different provider number as it has historically been known. Within a hospital, for example, the infection control might have their own sub-organisation, the emergency department, etc., depending on how the system is set up currently. But that can be reviewed if you find that your organisation has many air provider numbers. You might be able to consolidate those and just use 3 or 4 for your area health service, for example, and that way streamline the sub-organisation process for you. Next slide, please. Okay, so once you've been registered as an individual, you can find the person within the organisation who will be able to add you as a member. They will be the person who will also add the air provider number to the organisation's PRODA account. They might be asked some verification questions about the air provider number, such as postcode in which the air provider was registered, and sometimes you're also asked for the BSB number, but those, if you don't have them, can be overcome by contacting AIR, and they might be able to assist you in processing your link to AIR without them. Next slide, please. Okay, so this is much the same, just the nominated PRODA representative will add the individual members using their RA number and the surname with which they've registered with PRODA, and then they'll give them an attribute, which is what kind of level of access they need to the AIR, whether it just be looking at AIR records or whether they can also themselves add other members or have more of an owner type attribute to the PRODA account, giving them more level of access. Next slide, please. So these are the user guides which assist individuals in registering with the PRODA and also with registering the organisation. So if you haven't seen these before, they're very useful, and they have lots of contact information to contact the AIR with to help you with any issues that you come across. Next slide, please. I just put up some contacts here. These are the AIR Service Australia contacts, and they've increased their operating hours recently with the increase in COVID queries, and also trying to assist people in registering with PRODA so that that's all completed before the 30th of June cutoff this year. Thank you. I think that's the last of my slides.
Dale, I've got a couple of questions for you.
Yeah.
Katie, I just missed the date that PRODA, the PRODA date, and also where can we access the user guides, please?
Yeah, so the date is the 30th of June this year, 2021, is the cutoff to transition to PRODA, after which time the authentication files will no longer be viable. And access the user guides. I'm not sure if they're available online, but I am happy to distribute to those, or if I can find the link, I can distribute the link after the talk.
Excellent. Thank you very much, Dale. Just introducing our next speaker, Dr. Paul Leffler. Paul's our Senior Medical Advisor, and he's just going to give us a COVID program update. Thank you, Paul. Will he need the mouse? Thank you very much.
And how do we?
Just click.
Right click and it'll go?
Yep.
Alrighty. Good morning, everyone. We'll just cover COVID vaccines really quickly, and then in the context of the flu vaccination program. So just to get everyone on the same page, and because a lot of what we're seeing, a lot of the concerns and issues that we're seeing around the vaccines is related to their structure. I just mentioned briefly that obviously this is a schematic of the coronavirus, and for all the vaccines that I know of that have been licensed so far, all of them are targeting that spike protein, which is a very prominent feature of the virus. And that's where you're seeing some mutations occur and some issues about variants of concern are in that spike protein. There are other targets, and I understand vaccines are in development into some of these other proteins, but I don't know any that are actually in use right now. So the first of our vaccines is the Pfizer BioNTech vaccine. And this one works by actually having a fat bubble, that lipid nanoparticle as it's called, and they have messenger RNA within the fat bubble. And how this works ultimately is that the messenger RNA there in that little red squiggle goes with the fat bubble and then can merge with the cell, because our cells linings, our cell walls also have lipids, and so basically they can merge, and it inserts its mRNA or releases it into the cell, which goes on to be turned into the protein structure within our cells. So we make the protein, the spike protein, and then that gets presented on the outside of the cell, and it also gets chewed up and presented by special antigen presenting cells. And so that's how the Pfizer vaccine works. It turns out that fat bubble was very and the mRNA inside it is very sensitive to heat, and that's why these vaccines need to be kept at -70 for most of their life, other than for the last little bit in the 5 days that it can be kept at regular refrigerating temperatures, because that is pretty unprotected, that mRNA, and it degrades easily. Now the AstraZeneca vaccine is very different in some ways, but very similar in other ways. So the way it's different is the AstraZeneca vaccine has a virus that can only grow in certain cells, because they've taken genes out of the virus that it needs to replicate, and they have those genes in the cell line that produce the products that the virus needs to be fully formed. So once you take the virus out of that special cell line, it can no longer replicate. So when it goes into a human, it can't replicate. The other thing they've done, in addition to removing genes so that it can't grow, is they've added DNA that actually makes the spike protein. And so it works pretty similarly. That virus particle gets injected by a needle, goes in and releases its contents, which ultimately make the DNA makes its way into the nucleus of the cell, where it makes mRNA, like we just talked about. And that mRNA, it doesn't travel to a new cell. That's the same cell. It comes out of the nucleus and basically does exactly, if that drawing on the right looks like the Pfizer vaccine drawing, it should, because they work exactly the same from this point. mRNA being turned into, but the ribosomes turning it into the spike protein and then being presented. So we would expect there to be some similarities between them in many ways, and then differences related to how they're delivered and their stability. Now that virus particle is actually pretty tough, so that vaccine can be kept at 2 to 8 degrees, our regular refrigeration temperature. So it has a huge advantage over the Pfizer as far as managing the cold chain. I probably got one more error there. Couldn't stop myself yesterday. So there's been a lot of discussion about which vaccine is more effective. And it's hard to compare them head to head from the clinical trials, because the clinical trials actually are different in many ways. The ages and comorbidities of the patients aren't necessarily the same. There can be other social determinants of health that are different in the patient populations. Seropositivity to COVID can be different. You can have different strains circulating in the community at the time. The force of infection, if there's lots of infection around, it can impact the VE estimates. And what you call a case. Is it somebody that has symptoms and is lab positive? Is it somebody that has severe symptoms and is lab positive? Is it somebody hospitalized? So all these different things about how a case is defined and how a case is identified can vary between studies. So it's hard to compare them head to head. But what we saw in those initial trials was that for AstraZeneca, the vaccine effectiveness was 67% when they combined data from Brazil, the UK, and South Africa. And that was not very impressive because Pfizer had already come out with a study from the US showing it was 95% effective. However, when the data were reanalyzed, and I'm going to show you the real world data that's just coming out in the last week or two as well. When the data were reanalyzed from the study, people that got an AstraZeneca dose 12 weeks apart, the vaccine effectiveness was 81%. So getting close to what Pfizer had in its study in the United States. And that's why we're using a 12-week interval for the AstraZeneca, because we want to get that higher effectiveness. And this is a concept we often see with vaccinations, to be honest. Longer intervals between doses tends to be helpful. So that's just the recently published in the Lancet in March 6th. Now let's go to real world data that does compare both of them pretty much head to head. This is a study from Scotland in the last couple of weeks with slightly over 5 million people under surveillance. In this paper, about 500,000 got AstraZeneca and a little bit more had received the Pfizer, the BNT vaccine. And because they're rushing to get this data out, they're really looking at short intervals of effectiveness, and they only had one dose data available because they're waiting 3 months between the doses. But what you can see here is one dose of the Pfizer BNT was 85% effective at preventing COVID-related hospitalizations, and one dose of AstraZeneca was 94% in this same environment. And so I'm not saying one is better than the other based on that. And in fact, this is that study broken down by the effectiveness for weeks after, days after the vaccination, actually. And you can see they pretty much run parallel. And those little lines show that the confidence intervals for the vaccine effectiveness, they overlap. So there's nothing to say that the vaccine, one is better than the other in this study, but it does look like they're performing similarly in the real world, in Scotland at least. So the third study is another real world. This is the Avon CAP study. It looks at elderly and frail people in the UK, people aged 80 years and over that are hospitalized for respiratory illness. It's a case control study where they look at cases and see those ones that were vaccinated versus those that were, and what proportion had COVID. And essentially, you see one dose of the Pfizer vaccine is 79% at preventing hospitalization 4 to 5 weeks post-vaccination, and AstraZeneca is 80%. So identical in my view, in that study. And then the last study is also from the UK. It's people age 70 and over, of which there are 7.5 million. It's a data linkage study in England. And essentially one dose of Pfizer is 61% effective at preventing COVID illness. So that's non-hospitalized as well as hospitalized, and one dose of AstraZeneca was 60%. So again, we see these similarities, and if in that study they actually looked at people who had breakthrough infection, so they were vaccinated but they still got infected. If you had a dose of Pfizer, you were 44% less likely to be hospitalized, and a dose of AstraZeneca, 37% less likely to be hospitalized if you had breakthrough infection, which is, I think, the outcomes we're most concerned about that we want to prevent are hospitalizations and deaths. And again, to me, I look at those and say those are pretty similar. So right now, based on the available real world data, there's not a lot to say one is going to perform better than the other in the real world. So what about safety? I'll just jump to the chase here. There's been a lot of discussion last week about blood clots occurring after receiving the AstraZeneca vaccine. This has not been an issue, at least to my knowledge, associated with Pfizer so far. So essentially, there are people that getting blood clots after vaccination, but the major types of blood clots, the deep venous thrombosis, the DVTs in your legs that break off and go to your lungs and cause pulmonary embolism, those are actually really quite common, in the world. So they are going to happen after vaccination. And so, but because it was raised in this was investigated. But before the results of that investigation, what we saw was countries around the world stopped using AstraZeneca. Here's a map of all the countries. Essentially, this fear spread like wildfire in having countries drop out, or I should say pause their AstraZeneca vaccination programs, why this got sorted. And you can see that didn't stop the politicians from jumping in, saying everything's fine. This is from March 12th. I would suggest not getting your vaccine safety data from politicians if you can help it. But fortunately, there are other sources of information. So the European Medicines Agency, which is obviously responsible for the EU, looked at all the data available and came out with a statement last Friday. And I'm quoting it here. I might have cut some words just to make it shorter, but otherwise it's direct quote. The vaccine's not associated with an overall risk of blood clots, thrombotic events in those that receive it. So DVTs, PEs, it's not. However, the vaccine may be associated with very rare cases of clots associated with platelet destruction, including rare cases of clots in the vessels draining from the brain. And so with 20 million people in the UK and EU that have received the vaccine, there have been 18 of these cases reported. So there isn't a causal link. It hasn't been proven that it's related to the vaccine. And COVID infection itself is prone to causing thrombocytopenia and clots. So people wonder if that's not a factor, that maybe these individuals actually have mildly symptomatic or asymptomatic COVID infection. But it is something that needs a further look at. But on balance, the benefits outweigh the risk, because we're talking about approximately 1 in a million risk of this side effect if it is in fact caused by the vaccine, and that we don't know at this time. Again, they say don't get your information from politicians, but they certainly seem ready to stand up and give the news. And this was the good news that the UK was putting out after the European Union's report. But having said that, I would like to draw your attention to, as we roll out AstraZeneca vaccine more widely, this is our data that we get from sending an SMS to people that have been vaccinated, and they respond whether they had a reaction or not. So this is recent data. I think it was compiled on Friday. You can see the number of respondents by vaccine brand. What I want to bring your attention to is really the third column in, which is the common side effects. You can see about 50% of people have with AstraZeneca have injection site pain and swelling. More than 50% have fatigue, 50% with headache, 50% with muscle aches and pains, and 30-some% with fever are being reported for AstraZeneca. This is higher than with Pfizer. As you can see, that same column there, it's still significant with Pfizer. So I think we do need to be advising patients that they are likely to have a reaction after either vaccine, but especially the AstraZeneca, that this is common and to be expected based on our data. And in fact, we're seeing that the people reporting absenteeism from work after AstraZeneca is not insignificant. So if you're planning on doing your whole workforce, if you're using AstraZeneca, you may want to stagger the immunizations, or both, either vaccine, but especially AstraZeneca, stagger the administration to be over several days so that you won't have reductions in your workforce following that. Now, you might ask, why would that be the case? Because I just showed you the schematics of how they work, and they both work pretty similarly by causing a spike protein to be built inside our cells and presented on the outside of our cells. Well, I don't know this to be true, but I think the difference is that viral vector that's used in AstraZeneca, I think it really fires off our innate immune system. So we have adaptive immune system, which is essentially when we get exposed to something, we grow antibodies and T cells that can respond to it in the future. But we also have an innate immune system which fires immediately when we get exposed to a new pathogen. And I have to think that it's related to that structure of the AstraZeneca vaccine being an actual virus, appearing like a virus as opposed to a fat bubble, because lipids don't tend to be very reactogenic with the Pfizer. So that is my unsubstantiated hypothesis of why we're seeing this reactogenicity with AstraZeneca. All right, and with that, I'll take some questions. I do want to say thanks to you, the audience, but also that's Professor Chris Blythe getting his vaccination. I stole one of my slides or some of them from him, so I want to thank him personally as well. Looks pretty happy to get a jab there, doesn't he?
He does. Thanks, Paul. We just have two questions. So the first one's from Marie. What do you suggest in the case of someone on chemo who has a small PE? And the second question, is it still recommended that you take Panadol prior to AstraZeneca vaccine administration?
It's not a, we'll do the second one first. It's not a standard recommendation to take Panadol before you get AstraZeneca, although they did use it in one of the clinical trials to try and reduce the reactogenicity. So I have Chris Blythe and I were communicating about this because he's on the Australian Technical Advisory Group for Immunizations. Are we going to make a national recommendation to say that based on what we're seeing? It turns out when you look at the clinical trial data, it's not clear how effective taking Panadol prior to vaccination really was at reducing the symptoms. But that's a discussion that will be had over the next couple of days, and I think we'll have a firm recommendation out shortly. And we need to get it out because, you know, today's the day GPs are all starting to be able to, well, I shouldn't say all, many GPs are starting to be able to vaccinate. So we're going to have a lot more people receiving it. And then the first question again was?
So this is, what do you suggest in the case of someone on chemo who has a small period?
Well, generally, I can't advise on an individual patient, but generally people that are immunocompromised and with underlying medical conditions would be recommended to be vaccinated. Right. So there's no evidence to suggest that the AstraZeneca vaccine is related to clots other than that very very rare 1 in a million type of situation. So there is no recommendation now to say don't use AstraZeneca in people that have a history of clot or currently a small PE. So either vaccine would be fine, but they should be vaccinated because if they get COVID illness, they'll be in a much worse position than perhaps other individuals would be because of their underlying conditions.
Excellent. Thanks, Paul. Thank you very much. And now we've got to our last speaker, Dr. David Smith, who's a clinical microbiologist at Perth West. And David's going to give us an influenza overview.
Thank you. Can you hear me okay there?
Yes, thanks.
Yep. Great. Okay, so I'm going to give you a little quick tour through influenza or the lack thereof, and particularly to focus on a couple of things. A new one is the behaviour of influenza, of course, this year. A little bit of about new antivirals and a brief mention of the cellular vaccine, which is now licensed here. So. No, I think you need to change the slides for me. Yep, next one, thanks. So just a reminder, there are actually 3 major species of influenza viruses around, or 3 major types. We're only going to talk about influenza A and B because they're the ones that cause the significant public health and significant personal health burden from influenza. And influenza C is a very different sort of virus. It doesn't behave the way that the other 2 do, other than causing mild respiratory illness. If any of you read more widely, there is an influenza D, but as far as I can see so far, it's only affected cattle, so most of us should be safe. The influenza A, of course, is the one that attracts most of the attention for us. It's the one that crosses species, so it can jump from animal species into humans, and is the one that is responsible for new pandemics. It undergoes 2 types of change, and we'll look at those in a moment. So it causes pandemics and then seasonal epidemics as well, of which there are now about 16 different types, but only 3 of them have been demonstrated in human populations as an actual human epidemic strain. So that's the H1, 2, and 3, which we're familiar with already. Influenza B, of course, doesn't cross species. It's been in human populations for as long as we have records, and we haven't had any entry. If you see, we do talk these days about 2 lineages of influenza B, but they're not different subtypes like we see with influenza A. But it does undergo ongoing antigenic variation over seasons. So it causes seasonal epidemics, but not pandemics. Next one, please. Can I have the next slide? Thanks. And this, I like this little chart. It reminds us of what influenza, particularly in a year where we've had all of our attention really focused on COVID, And this is some stuff that came from AIHW, which looked at the impact of a range of vaccine preventable diseases. And you can see the big blue circle up in the right-hand corner there shows that influenza overall is the most significant burden in terms of vaccine preventable diseases. Now, of course, within an individual, influenza doesn't have the same likely impact as pneumococcal disease, but a lot more people get it. So it's really that total burden of disease that occurs within the community, and really what we're trying to aim to reduce with vaccination programs, which will both, of course, reduce that whole burden, as well as providing protection against individuals from infection and more severe disease. Next one, thank you. And that's, again, it's really this whole burden of influenza that's important. And there's been a lot of attention on pandemics and pandemic potential, and we know that those make a lot of people ill and kill lots of people over 1 or 2 or 3 years. And indeed, the patterns we've seen with influenza are similar to what we're seeing with COVID, with that rapid spread of the pandemic over the first 2 or 3 years. And we don't know what's going to happen with SARS-CoV-2 yet, but with influenza, generally that pandemic strain, well, always that pandemic strain has settled down to become an epidemic strain. And it's no doubt the total burden of influenza is largely dependent upon epidemic influenza. We often call that seasonal influenza, but of course that ignores the fact that not everywhere has a season and the seasons vary. So a more correct term is interpandemic influenza, but bear with me if I slip into the term of seasonal influenza. We also know it still remains the most serious of the respiratory virus infections. You know, maybe SARS-CoV-2 will knock it off its perch, but that remains to be seen. It's both due to direct virus-related disease, but we know that a significant and the major portion of the health burden related to influenza is its secondary effects. We know secondary bacterial infections, particularly secondary pneumonias, are important with influenza, but the biggest burden again is the exacerbation of pre-existing chronic illnesses. So people who get knocked off because of their heart disease or their lung disease, which has been precipitated by getting influenza. The other course with influenza is immunity is transient, and we know, and I'll talk, I think I'm saying it a little later, that we know that good protection from either natural infection and even more so with vaccination is only lasts a matter of weeks or months. And it's dependent both upon time, but also because the virus, of course, changes to varying degrees year by year. The other thing that's great about influenza is it's both preventable and treatable, and we'll talk about both of those aspects as we go through. Next one, please. So again, many of you will have seen this picture before if you've seen any of my talks. But again, it's the important things about influenza which are there. One is that there are 2 proteins which are of particular relevance, the hemagglutinin and the neuraminidase. So most of what we talk about with influenza relates to the hemagglutinin. That's the bit that binds to the host cell receptors, and it binds to the sialic acid receptors, which you need to remember, it's important later. And is also the one that we talk about when we type it as H1, H2, H3, and then as it goes down further into the actual further classification of the viruses. And it's also where we know the major determinant of protective immunity occurs, is having antibodies to those hemagglutinin spikes. The neuraminidase, when we talk about the neuraminidase inhibitors, we'll see a picture of that, is important in the replication of the virus. It's not as important as hemagglutinin is, but it's certainly another important protein, and one which we do develop antibodies to as well. They're important in our protection. The other thing with influenza, those purple lines in there, illustrate the fact that it is a segmented genome. They're little packets that actually each code for an important protein. And that's why it's so easy for them to change, and they can exchange these these segments with each other, and of course between human and animal viruses, which is so important in generation of pandemic strains. Next one, please. Okay, there are two ways I mentioned, it's probably been alluded to in some of the previous ones, that the nature of genetic change that occurs in influenza viruses. The one we see every year is this antigenic drift. And influenza is always changing. And it changes largely driven by immune pressures. And it's immune pressures in humans for seasonal influenza. They're human viruses. There's nowhere else it's liable to happen. And if you look on the right there, the little red sections are the sections which are targets for neutralizing antibodies. So when we develop our immunity to a particular strain, it's largely directed at those little red areas. And that's the bit that is driven to change. Now, influenza viruses have the features of nearly all RNA viruses in that they really are not great at repairing errors in their RNA as it replicates. So it's always changing, and every so often it'll spit out one that codes for a protein which our antibodies don't protect against, and that allows new strains to emerge. And if you look at that little picture and the black bit, the important bit for the virus, the receptor binding site, is right in the middle, and it's not the bit that changes. So the virus can change its the proteins that are important for neutralization without affecting its function, which makes it so well adapted to being able to change. Now, and I will say that for some of you who've read the stuff about SARS-CoV-2, SARS-CoV-2 does have an RNA repair mechanism. It's different from flu. Whether that's going to change its behavior and make it less prone to change than influenza, I'm sure it will. How much it will affect it remains to be seen. The other major mechanism, the one that generates pandemic strains, is antigenic shift. That's where you actually get a new strain of hemagglutinin or a new type or subtype of hemagglutinin that is so dissimilar from the previous one that large proportions of the human population are all susceptible to it, which allows you to have multiple epidemics all over the world. The main one, as I mentioned, is reassortment, that bit of exchanging them. The others, though, can happen just by a series of mutations that change it enough to become different and escape global immunity. Next one, please. So that's what happens. We know that influenza, now we're talking about pandemic influenza here, the one that skips from humans from animals into humans. They exist in the migratory bird populations of the world, and they will always be in those populations. So we're not going to get rid of influenza unless we get rid of everything, all life, I guess. And there's this ongoing mishmash of exchange of genetic information occurring between birds over a whole variety of animals, and of course people, though we're not all that important in that. Pigs have been implicated as being important vectors because pigs can be infected by both human and avian and other animal strains of influenza. So they may be an important mixing vessel, but that remains circumstantial evidence. It's also true that most of our new strains have emerged in the parts of the world where there are very dense populations of people, of birds, and of pigs as well. But again, circumstantial evidence. Eventually that spits out a new pandemic strain, which causes a pandemic in humans of varying size, and then they become, as I said, one of the seasonal strains, and they go on ongoing change each year. Next slide, please. So that's where we are at the moment. We know from historical serological studies of older people that there was a strain in the late 1800s, which was an H2, which was replaced by an H3, which was replaced by an H1, which was then replaced by an H2, which was then replaced by an H3, in 68. Then since 77, we've had 2 strains. There was a re-emergence of an H1 virus then in 77, which didn't replace the H3, and they've co-circulated ever since. And as you know, in 2009, we didn't get a new H-type enter. We got a very different H1 appear that caused the 2009 pandemic. So we now have every year 2 subtypes of influenza A. The other thing that happened with B, which as far as we know has always been there in human populations, is that in the 1970s there was a break-off group which became quite different, and that created 2 lineages, the B Victoria and the B Yamagata, which of course is why we wanted to have 2 B strains in our vaccines, and we now do. So we now have those 4 sort of important antigenically different strains circulating each year in global populations. Thank you. Next one. What we're also now seeing, considering some importance, is that we can divide our H3s into clades. Now, you don't have to remember any of these, but when we start talking about vaccines and egg adaptation, which has been a problem, that appears to relate to these C3, particularly C3, 3A strains, which have appeared and have become the important ones circulating. So knowing further variation within our subtypes is biologically important, particularly in terms of host immunity and vaccine-induced immunity. Next one. So there they are. There's the pandemics. We've seen one which was a recombination event, which was a 1918 one, and the others were reassortment, 57, 68, and 2009. And I think we've talked about this mechanism of reassortment, and you can see on the top one about how you get a mixture of avian and human and animal segments in the virus. 2009 was what we call a triple reassortment. It had a strain which already had avian and swine sequences in it, then mixed with a human one, so there was a bit of all 3. So next one, thank you. And we know previous pandemics, that's the mortality patterns, that's 1892 and 1918 on the left, and 57 and 69. In both of them, you can see an increase in mortality in older populations beginning around 50 or 60 years of age, much more marked in 1892 and 1918. There is also an increase in mortality in young people. It was not as evident in the later pandemics. And indeed, in 2009, while lots of kids got ill, mortality was very unusual in them. Also, I think the figures for the later ones don't have as much data from children in them. What is different in 1918 has always been the worry with pandemics is this big peak occurring in young adults. And of course, we saw a component of that in 2009, probably for different reasons. But we know that influenza A does have the potential to create serious illness in younger adult populations as well. Next one. And that's 2009, excess compared to 1918. And you can see there, don't know why that figure's so low for the older age group in 1918, but the main point here is that we did see an excess mortality in the younger older adult group, particularly that 20 to 60-year-old age group with 2019, and that was really where the outstanding feature of the 2009 pandemic. Next slide, please. So the thing we see each year, influenza seasonality. What we, this is just to show you, the left is the data we have for the percentage positive test results. Most of you will be familiar with it. The reason we use percentage positives is it, with influenza, it corrects quite nicely for increases in testing behaviour, so that we know that when we see the peak, it isn't just because more people are being tested, but the people who are being tested are much more likely to have influenza during that period of time. I've chosen that particular graph, and you can see also, I think, on the right-hand side, the figures that go back, and we've seen regular periods of activity nationally in our cooler months. In 2009, of course, stands out there. The increase in numbers that you see post-pandemic compared to pre-pandemic are not accurate reflections of activity. We know that since the pandemic, a lot more people got tested, and these just are total numbers. And you can see, whilst some of those seasons look much bigger, when we look to the left for those seasons where we had percentage positive, there's a lot more similarity in the pattern of seasons and the severity of them. So you do need to correct for changes in testing behaviour. So there's some estimates, you can read that yourself, and there are estimates of 200 or 300 deaths per annum in WA, most of which will be unrecognised, and that's true internationally. What I do want to say is in tropical and subtropical areas, it's why this idea of seasonal flu is really refers to the temperate climates of the world, because in many others you have either two seasons, or in places like Singapore you don't have a season, it's there all year round at roughly the same level. And Australia has two seasons, and because in our tropical and subtropical areas we do regularly get activity occurring in the summer months. It's just that we probably haven't recognised it as often because of the population size just isn't big. And certainly with WA testing, which is much less frequent in our northern parts prior to the pandemic. But there clearly is two seasons. Now, that's not to say it's heavily dominated by that winter season. And indeed, even our tropical and subtropical areas, of course, you get a peak occur in those months as people move the virus into those areas as well. And next one, please. That's what we know. Incubation period, 1 to 4 days, typically around about 2 days. The virus doesn't have to go far before it causes disease, just from your mouth to your respiratory tract epithelium. We know that viral shedding can begin a day or two before symptom onset. Adults typically shed for 4 to 7 days, and children for a bit longer, 10 to 14 days. The transmission, look, I put this slide there, that's a talk in itself these days, transmission. But there is transmission that occurs via large droplets, and we talk about this distance of 1 to 2 metres. We're increasingly learning from our experience with SARS-CoV-2 lessons that we should have learnt before, that one setting any distance on it is a construct of the human need. And that the virus doesn't always behave like that, depending on what's happening with airflows and human behaviours around that. But it's also true that coughing, talking, sneezing, laughing, as you go into concerts and all those sort of things is going to increase it. Aerosols are associated with broader spread, and they're the ones that we look at longer distances. And there are various experimental models, and ferrets, they look at the fact that does it spread just to the ferret in the next cage, or will it spread to a ferret in a cage that's quite distant from there? So there certainly is longer distance spread. I'm not sure that there's a strict border between large droplets and aerosols. But they are different, and they require different control mechanisms. And then, of course, this issue of survival of viruses on surfaces, which in some situations may be up to several days, and the potential for spread via contact, largely contact on our hands from other people's hands or objects, and then touching of the face and nose. Next one, thank you. And clinical illness, of course, is important. most of what we see is uncomplicated illness with this acute onset of fever, sore throat, muscle aches, etc. We've had a lot of discussion around this in the last couple of years about how much unrecognised influenza occurs because of asymptomatic infections, which we used to think were uncommon, if not rare, but it looks like, particularly in paediatric studies, that it's not that uncommon, in fact. And that probably does contribute to spread, though it's true that people with symptomatic illness will shed more, both because they have higher viral loads and they're more likely to be coughing and sneezing and spreading it around. But it is important in understanding the behaviour and risks that there will be people who are infectious and unrecognised as being so. What has, from a human health perspective, focused a lot more on the complications. And I've mentioned a number of these before. A pneumonia, which can be primary viral or secondary bacterial. A number of those respiratory pathways or airways illnesses that you see in kiddies. We see a reasonable incidence of myocarditis in people with influenza and deaths from myocarditis. And myositis or inflammation in muscles is well described. And then a number of neurological complications, including febrile seizures, encephalopathies, Guillain-Barré syndrome, that progressive paralytic illness, and Reye's syndrome, which you see in kiddies with an encephalopathy and liver failure, and it's associated with aspirin use and influenza. Exacerbations of underlying disease, as I said, are with a major burden. Chronic lung diseases, including asthma, cardiovascular diseases, diabetes, neurological disease, and really anything else that makes people a bit of a crumble. So people who are have a number of underlying illnesses and their health really just is not that good. And then, of course, death, which is something we tend to focus on because it's a fairly dramatic outcome, but it's not the major burden associated with influenza. Next, thank you. Oh, and I will say one thing about death, you don't have to go back, is that the way we classify death has changed in that we recognise, particularly in 2009, that there were a lot of people who would have died in the previous pandemics who were not because they went into ICU, they were ventilated, and some of them went on to ECMO. So there is a tendency now to start classifying ICU admission or the need for ventilation as a marker of severe disease, because it, as I said, people do better these days than they used to. And you have to remember the last big pandemic, even respiratory support, ventilation was an uncommon thing to happen. Okay, next, thank you very much. And this is the one I trot out. It's not particularly up to date, but the idea is roughly correct. And it's really meant to illustrate that total burden of disease where we see deaths as the peak of the pyramid, but there's a huge burden then that goes on with hospitalisation, medically attended visits, acute respiratory disease that doesn't result in medical attendance, but it results in absenteeism and all that. And then just our total infection rate, which in any one year is between 10 and 30% is the estimates for that. Thank you very much. Next one. And this is some data. Carolyn will know this very well. And a few people from Health Department worked with our people at Pathwest to gather data regularly on what we see from fatal cases of influenza. And whilst I mentioned that mortality is not the main burden, it certainly is nice to illustrate what we see. And the colours are a little similar that it's been assigned to me here. But what you can see there is if you look at the pattern that we see of mortality does vary with the type, and that it peaks with H3 is very much the one that overall, of course, is the most severe of the influenza subtypes. And it has a very marked tendency to be the older you get, the more likely you are to get knocked off by it. And interesting, of course, H1 And we've always seen a pattern with H1 where we tended to see a bigger burden of disease in the working age adult population. And it's reflected here in the mortality figures. And it really was pushed to the forefront with the H1N1 pandemic when we saw that shift of pattern. And then when you look at influenza B, we see a pattern which, again, with a relatively larger number of cases in young people. Now, these are proportionate things, so it doesn't reflect that the majority, well, it shows the majority of the impact in severe disease and mortality is H3, and they're the bad seasons that we typically see. Next, thank you. And this is here illustrated again, and you can see that pattern there of the one I want to show in this one, typical pattern for H3, was this H1 curve, which shows that little plateau which goes from about the sort of some people in that 25 to 44-year-old group and right across to the older individuals. Now, we know that part of that was because older individuals had some protection from infection, and if they got infected, they did badly. But it did illustrate the burden that we were seeing in that younger, older adult population. Thank you. Next one. Okay, now I showed you that one up to 2018 before. I'm talking a lot about pre to 2000 because we know we didn't have any flu in 2000, or only teensy-weensy bit. And you can see here that we had those very regular patterns occurring until we got to 2019. And then we had that very early flu season, and that was a national phenomenon, and that's the light blue line. And you can see it was remarkably early. It was not never seen before. When I look back on some of the data, we had a very early season in 97. And so, but it's, you know, it's a once in a lifetime phenomenon, if you take, or once in a generation phenomenon to see it that early. And we were trying to get to the bottom of it, then COVID came along and distracted our attention. So yes, we do get that movement around, and you can never be overconfident about the pattern we're going to see with influenza, which can make choosing of when you vaccinate a bit tricky. But I still think you go with the big numbers, which for us are a season beginning in the second half of the year. Next one, thank you. And if we look here, the other thing is it's not the same everywhere. So that was the 2019 pattern. And it was remarkable, the variability we saw in different states, both in terms of when it started and how long it went on for. In many of the states, they said, oh, look, it was such a long season. And it wasn't all that long a season for us. It just was early and a short, sharp season. But it reminded us how bad an influenza epidemic season can be. And it's almost, and a bad a bad epidemic season is as bad as a mild pandemic, and possibly worse. So we've always got to be on our toes. So next one, thank you. Oh, I think that's just the same to show you 2019 using our laboratory figures, and you can see that we have a fairly regular pattern of activity. There are some years which are quite small, but you've got 2009, as I mentioned. 2007 was a big year. 2009, of course, was the pandemic year. And then we've had a number of quite bad seasons in between those two. And then, of course, 2019 was huge. Next one, thank you. So WA, there's a couple of things here. I mentioned about that summer season, and you can see it The left is our influenza average epidemic curve. And it does show this little bump back there in the early part of the year overall. But the recognition of the summer activity has really just been in the last few years. And I think if you look on the right there, which is our percentage positive rates, I'm sure they bounce around a bit, you do see this consistent pattern there in the first part of the year. In people who have returned from overseas with flu, but it also reflects activity occurring in the north of the state. If you look at the purple line there, which is last year, you know, we looked like we were about to start and then it disappeared. And that is an impressively flat influenza curve there. Actually, you can't even call it a curve. And if you look at the red line, we're flatlining again this year so far. And most of the Northern Hemisphere has flatlined as well. So we'll maybe talk about that further on. Next slide, please. So this is my report on influenza 2020, largely. And I quote here from the WHO Collaborating Centre, and I'll read it to you. It has been an exceptionally quiet year for influenza around the world, due in part to restrictions on travel and social distancing measures that have been in place for COVID-19 pandemic. That's probably an oversimplification. That certainly likely had a major impact on it, but we're still trying to completely figure out what's influenced that. And all of our respiratory viruses have disappeared, with the exception of rhinoviruses and parainfluenza 1, which again is interesting. It is, and the other quote is, difficult to predict when, where, and how much influenza activity will return and which viruses will circulate. So that certainly has caused problems in terms of the strain selection, because there's so few viruses around to know what the remaining viruses are likely to be, and therefore what's going to be around next year. Next one, thank you. And there it is. I mean, there's been a lot of discussion and people continually say, oh no, maybe it's just because we stopped testing for flu, because we were only testing people for SARS-CoV-2. Couldn't be farther from the truth. In fact, we did more flu testing than we normally would, driven by the fact that there were concerns about causes of respiratory illness. And this is from a thing that we did with around that national data showing what happened with emergency department visits. And you can see that a number of the system indicators were also extremely flat. And the bottom one on the right, C, shows our laboratory testing data, and you can see we did which is the and you can see that we did a huge amount of testing. And the red line there is rhinoviruses, which didn't go away during last year. So a lot of things to think about there. Lots of questions, and I would love to get some answers. Next slide, thank you very much. I'm not going to talk about testing because nothing really much has changed with testing. We've moved, of course, I spoke about it last year. There was a huge move towards more PCR testing as those tests were moved out into the community and into the private laboratory sector. That led to a significant increase in the number of cases detected. And it needed a little bit of correction then in terms of how well that reflected our true activity. And they've remained the mainstay. And of course, there are now the rapid tests, which we run in emergency departments particularly. I do want to talk to you briefly about antigen detection tests, because we're getting some reports of flu activity this year based on those, and they're not right. Now, antigen detection tests, of course, were came on the market before the PCR tests as point of care tests. They were not designed to be used in periods of time when there was no flu activity. A lot of our attention on antigen detection tests focused on the fact that they were not as sensitive as a PCR. So they would miss maybe 20, sometimes 30% of cases. So it meant that if it was important, you had somebody with an acute illness during the flu season, they were good at saying, yeah, if it's positive, they have flu. If they were negative, not so good at being confident about the result. The problem is they're not as specific as the PCRs either. That means that they will give you false positive results. And that's likely if there is no flu around. And that's what's happening at the moment, is that we will get results. If you use antigen detection tests widely in a population when there is no flu around, your positive results are going to be false because they can't have flu. That's not to say that there may not be some unusual circumstance, but you need to check your results before you act on them. The other problem we have with the antigen detection tests, and indeed with the number of the PCRs around, is we don't get to subtype the influenza A's or lineage type B. So we do need enough of that more extensive or more detailed testing to give us the information we need to inform public health. Next one, thank you. All right, a little gallop through where we are with vaccines and antiviral agents. Next one, thank you. Next slide, thank you. Yeah, thanks. So influenza vaccination. Again, we've had a lot of discussions in the past about this, but it's true, it prevents mild disease in the community as well as influenza-related hospitalizations and death. Overall, we know that effectiveness is around about 50 to 60% on average. We always used to say it was more than that, but the truth is out, and it sits around 50 or 60%. That in itself, and I'll show you some figures later, is a very significant effect. We know that severe illness is more likely in a group of people 65 and over, and therefore they're the ones where we would primarily target influenza vaccination in order to improve human health and reduce load on the health system. But of course, it has a much broader benefit in terms of reducing milder illness and economic impact, social and economic impact within the community. It reduces the impact of influenza both by reducing the risk of infection, and that is the major way it works, and may also reduce severity of illness in those infected, but that's a little more variable. And of course, we have two ways of using vaccination to reduce our impact: by vaccinating the individual to protect themselves. And of course, if enough of them get done, that protects the community as well. And reduce the likelihood of infecting others. And that's why we're looking at people who have contact with other people who may be at risk of more severe disease, either related to age or other illnesses. And that, of course, includes healthcare workers as a prime group who have contact with people at risk of serious illness. There's, of course, also now been, after WA led the way with universal vaccination of young children, or offering at no cost universal vaccination of young children, the rest of the country has finally caught on, and that's happening there. And we know that if you're going to achieve a degree of herd immunity, that is where even people who are not vaccinated are protected, then you need to get high rates of vaccination within children who are the prime spreaders of the virus. And we know they shed more virus and for longer periods of time. Next one, thank you. So how does the vaccine production go? Well, it's a twice a year process. A Northern Hemisphere formulation and a Southern Hemisphere formulation. So the a number of laboratories, including the 3 national influenza centres, of which Pathwest here is one, send their influenza viruses to the WHO collaborating centre in Melbourne, where they undergo detailed genetic and antigenic typing, and that allows them to identify which strains and how far they're drifting away from protection induced by previous vaccines. So then there's a biannual meeting for WHO, and then Australia has its own one, following up from the relevant WHO meeting, to select the best strains for inclusion in the upcoming season. So who meets in September for our next year, and then the Australian Influenza Vaccine Committee meets just after that in late September, early October, to usually endorse that decision. That then allows about 6 months for vaccine formulation, testing and production. And you can see an obvious issue there for a virus that's continually changing, then it might change during those 6 months. So it is a bit of, it's not fair to say educated guesswork, but it is a judgment call about which strain should go in. And we'll talk in a moment about the additional problems of adaptation. Next one, thank you. So I was trying to move them myself. The influenza vaccines we used in Australia prior to this year, all of the licensed vaccines available were made from virus grown in eggs. Of course, once the virus is produced, it's inactivated in what we call split. That means that the hemagglutinin particularly is the proteins in it, and the main ones are the hemagglutinin and neuraminidase, are split. They're disrupted in various ways. And that reduces the tendency to cause reactions. So all of them are split vaccines. The variables that you may see within the different vaccines are the number of different antigens. Until a few years ago, all of them were trivalent vaccines, which contained antigens, one antigen from what we thought the best H1, the best H3, and one influenza B. You could only either put one from the Yamagata lineage or the Victoria lineage in. And that was always a bit, again, an extra bit of having to make sometimes quite difficult calls about which one to put in. Now, there may be one, certainly internationally, there's still some trivalent vaccines around, but not many of them. And I think in Australia, it's all quadrivalent, certainly the ones on the NIP, also called tetravalent vaccines. And if you say, well, why didn't we do it earlier? It was because the technology didn't allow them to put 4 antigens in to the vaccine. That improved. The vaccine manufacturers improved that process so we could then put 4 different antigens in. The second thing is we recognise that certain groups, in particular that large group of the 65 plus, is that those vaccines we generally used just didn't produce nearly as good a response to that. So there were 2 approaches taken to that. One was to just put more antigen in it to give it a bigger boot, which does make it more reactogenic, but of course older people tend not to react either as much, so it was a swings and roundabouts there. Those and the other is adding an adjuvant, and adjuvants are a range of chemicals or compounds which stimulate particularly the T cells and not just the B cells that produce antibodies, and these seem to boost the immune response. We know, as I mentioned, protective levels are best from about 2 weeks to 6 months after vaccination, so you do want to try and time your program so that your when you think your activity is going to occur is within that 2 weeks to 6 months after the vaccination program, allowing a bit of extra time at the front end for the program to run out, to be rolled out and delivered. There's a vaccine which has come online from Seqirus this year, which is a cell-grown vaccine, but it's not on the National Immunisation Program register at the moment, but I'll show you a couple of slides later when we talk about egg adaptation. And there are live attenuated vaccines which are used overseas, but none are yet licensed in Australia, so we're not encountering those yet. Next slide, thank you. I do just briefly want to talk about efficacy versus effectiveness. We do talk about vaccine effectiveness largely, but when vaccines first come out, and which is certainly what they're going through with the SARS-CoV-2 vaccines, it's efficacy. And that's done in a controlled environment where you have a compare of outcome, a risk of infection or disease in a vaccinated population compared to an unvaccinated population, which means that you have to then follow them. Effectiveness is a way of measuring how well a vaccine program works in preventing, didn't need particular at the end, preventing influenza in the population. And what's also important when we talk about efficacy and effectiveness, it can be against a range of markers. And I think Paul's presentation before illustrated one of those when they were comparing the AstraZeneca and the Pfizer COVID-19 vaccines, that preventing infection and preventing illness were not necessarily the same thing in terms of their effectiveness. So we do need to look at if we want to look at community burden, then prevention of milder illness will have the biggest impact on absenteeism and that broader socioeconomic impact, whereas preventing severe illness and hospitalisation will have the greatest benefit to the health system, of course. For seasonal influenza, we usually calculate VE using what's called a test negative design, which compares the rate of vaccination in people who test positive or negative for influenza. So you would expect the rate of influenza in vaccinated individuals to be significantly lower than those in unvaccinated. So the rate of vaccination in people who test positive to be lower than the rate in people who test no, I'll just confuse everybody. That's how it's done. This reduces bias because we know that related to health-seeking behaviour, because we know they sought health, they presented with an illness and got tested. Also, one of the major determinants, now there are a lot of determinants in how effective a program will be. We know in terms of that and the vaccine itself, one of the major determinants is going to be how well the strain in the vaccine matches to the influenza strain that circulates that year. And that leads me to the next issue. Can I have the next one? Thank you. Which is how similar the strains are. Now, what we've seen is in the last few years with our H3 viruses, and remember H3s are the ones that tend to cause the most severe illness, is that the vaccine, the strain we choose for the vaccine, which then goes in eggs to be grown up for production of the vaccine, the virus changes when it's in the eggs, and this is called egg adaptation. And you can read, if you like, about glycosylation and that. It's not a genetic change of the virus. If you sequence the virus, it's the same. It's what we call a post-translational process. It's the way the virus changes after it's first been assembled. And the recent strains, these different clades, have had to alter themselves in eggs in order to grow well in the eggs. And so that's been a major determinant. And these ones, once they've adapted to the eggs, lose their antigenicity, which means the vaccine made from them just doesn't work very well. And that has been the problem for us. And that little illustration there is this is produced by the group in Oxford called antigenic cartography. And all those little dots are where are the antigenic location of the recently circulating influenza AH3 viruses. And what you can see at the top is the blue and red dot are where the vaccine grown in cells, so not in eggs, sits, and it sits there right in the middle of all of those, which is where you want your vaccine to be. When they grew them, the same virus in eggs, they sat way off the middle of there, and so it was some distance from where you wanted your vaccine to be. So that's been an ongoing problem. It's likely to continue to be a risk to us because of the same clades are still circulating. Next slide, please. And that lowered effectiveness, in fact, some years, as you will know, it went down to 25%, 10%, and possibly less with the H3s, which is a problem. We also know even some partial reduction in effectiveness is important. And this was a recent paper that they looked at some modelling to estimate what the benefit of increasing effectiveness. So they calculated what the benefits, this is for the US population, of a 5 percentage point increase in VE. In a low severity season, if you look at the fact we're looking at a total population burden, you're talking about 250,000 illnesses, about 1/8 medical attendant illnesses, and about 5,000 hospitalizations presented. And on a high severity season, that goes up 4 or 5-fold. So when we lose VE or achieve any additional benefit in VE in a population level, we can get a significant benefit from them, even if overall it doesn't look fantastic. Next one. So how do we increase effectiveness? Well, we can improve matching the vaccine with the circulating strains. And we do our best. In fact, we generally do a pretty good job, and the egg adaptation wasn't that the wrong strains were chosen, it was just that they changed after they'd been chosen. There's no doubt, but that is always a little bit of a challenge, particularly when you have a 6-month lead up between making that decision and when the vaccines will be put in people's arms. And of course, universal vaccines or broader acting vaccines are the holy grail. But so far, and there's certainly been progress, but there's still some ways away. You can increase your antigen content or the use of adjuvants, which we've done to make them more effective, particularly in those people who respond poorly. And there are ways of reducing this egg adaptation if we think it's going to be an ongoing problem, which it probably will be. One is to move to cell-produced vaccines, which I'll show you a couple of slides in a moment. Which have certain advantages. The main issues are that they can't be produced in anywhere near the quantities that are required for vaccination, and they're significantly more expensive. And there's no doubt that for the foreseeable future, we will be dependent on egg-based vaccines. You can choose viruses that don't undergo egg adaptation. Difficult thing to do, decide which ones do, but one way of doing it is you use egg-adapted viruses as your vaccine candidates. That means the virus has already been grown in eggs and it's shown good antigenicity even after growing in eggs. Unfortunately, we don't necessarily get a choice of those strains when it comes to which ones are available and suitable for putting in a vaccine, nor is even choosing egg-adapted ones necessarily completely solve the problem. So that's an ongoing challenge. Next one, please. One of which has been, because this is around, Sequira's kindly provided me with a couple of slides because they're better than anything I can make, regarding the cell-based vaccines. And really it just shows you there as it goes across that once the seed strains are chosen, they can be grown in eggs or they can be grown in these cell cultures in these large propagating vessels. Once they're done that way, they're treated exactly the same. They're purified, they're inactivated, they're purified, and they're put into the vaccine. So it's really just that middle bit, whether they're grown in eggs or whether they're grown in cells. Next one, thank you. And this is, as you see, Sequira's data, but they've summarised out of a number of trials. And it does show that there may be a slight benefit in effectiveness with the cell vaccines in the under 65s. There is data for the over 65s, but it doesn't show a benefit. And certainly for over 65s, you would 65 and over, sorry, you would still be looking at using one of the adjuvant egg-derived vaccines. Unless you really know you've got a problem with your egg-derived vaccine in that year. But a slight gain in VE vaccine effectiveness may be worthwhile, but this really needs to be panned out a bit more over a few more seasons. Next one, thank you. So, I should have finished off by saying, look, cell-based vaccines now are going to be on the scene. They'll be in the private market this year, and I guess they'll continue to make their case as to whether they should be considered for improvement on the National Immunisation Program. So there have also been some advances in antivirals. I better hurry up. The matrix protein inhibitors, which we've had for a while, are only for influenza A, and we are not using those anymore. The neuraminidase inhibitors are the ones that we've largely used, and they're the ones that work there on the end and prevent release of the virus from the surface of the cells. The group that has come online this year is one of the polymerase inhibitors. And if you look down the line, the polymerase there is that enzyme which allows the RNA of the virus to replicate itself. And if you block that, then you're not going to get viable virus coming out the other end. Next one, please. And I'm not going to go through this, but it's there for you guys to look at after if you wish, a list of the antivirals in current use. And I've mentioned the amantadine. It should be against amantadine, that they're rarely used now because of high levels of resistance, but they are still used a bit in some trials of combinations. The neuraminidase inhibitors, of which I've only listed 3, but I'll put the 4th one on one of the other slides there at the moment, all act in the same way, and I've already shown you. Oseltamivir is the one we largely use. There are 3 others which we'll see in a moment. And then the polymerase inhibitors as well. And baloxavir marboxil is the one that's on. Ribavirin is as well, but it never worked very well and it's quite toxic, so it's not used anymore for that purpose. Thank you. Next one. So, and there are a number which are in advanced development. A couple more of the polymerase inhibitors, favipiravir and pimodavir. Pimodavir actually won't come, by the looks of it. The company has stopped its trials because it didn't work very well. And a couple of agents which work on the cell receptors for the virus. One of them is called DAS181, which is going through evaluations, and the other one is a repurposed anti-parasitic drug, nitazoxanide, which also used to have activity against influenza viruses. But again, none of these are still in trial stages, so they're not yet coming into the market. Next, thank you. And the NIs have shown, they've been around for a long time. Oseltamivir has shown consistently benefits in both mild and severe disease and in hospitalization, and it remains a treatment, needs to be delivered here early, as all of these do, within the first 48 hours. Though you can go up to a week in people who have more severe disease and who are hospitalized. Next one, thank you. And whilst there have been concerns around resistance to oseltamivir, we do have overall the monitoring, and this is from a while ago, but it's stayed the same, that there is no real establishment of resistance occurring within the community to oseltamivir, so it can still be used as a first-line treatment. The problems have largely come in immunosuppressed patients where resistance emerges and is clinically relevant during their treatment. And zanamivir has never had much problem with the resistance. Can I have the next one, please? And there's the other 3. I won't go through it because they all are similar. Peramivir is a long-acting intravenous form of oseltamivir, which is very effective in mild and severe disease. Zanamivir is an inhaled drug, and lananimivir is a long-acting inhaled version of zanamivir, and they're zanamivir and peramivir are available here. I don't think lenanavir is as yet. Next one, thank you. This I'm going to leave you for you, any of you who wish to later read it, but it just shows you that we do get a variable effect with these three polymerase inhibitors on different bits of the polymerase, and they were active against neuraminidase inhibitor resistant viruses, most of them oral drugs, and they have effectiveness in uncomplicated and with baloxavir in antiviral and clinical efficacy. Sorry, but like many, resistance is a problem on sometimes. Next one, thanks. Baloxavir marboxil, it's an oral, it's a prodrug, it's cleaved to release the active drug, which is baloxavir, and it gets good blood levels from that. It's effective against A and B viruses, including NI-resistant ones, but it has its own resistance problems, and they relate to that PA138T substitution, which has appeared in up to 10% of patients in the trials at about 3 to 5 days. So you do have to watch out about that. It's given as a single dose, which has a very long half-life. As I said, it's been effective. Next slide, thank you. Both for treatment in that capstone trial, it was a bit more effective than oseltamivir, and of course a lot more effective in shortening illness and improving symptoms than was placebo. It also reduced in prophylaxis for household contacts. It reduced risk of influenza by about 60%. And it's very attractive as being a single dose that you can deliver, of course, either for treatment or prophylaxis in outpatient settings, particularly. Thank you. Next one. And then just these, I'm finishing now, I think. So what's happening now? Well, nothing is the answer. We still don't have much influenza activity internationally, and I'm really not sure what's going to happen this year. Next one. And this was the you saw this earlier. It showed what happened with influenza this year, that it thought it was going to happen, and then it didn't. And then COVID came along, of course, and it still hasn't come back. But I think it's going to be extremely important that we get the vaccines out there this year. There was minimal activity last year, and so we have a more susceptible population, and the possibility, therefore, of more rapid spread, including in our kiddies, of course. And I don't have time to talk about our RSV experience, but that's been very interesting. And there's been difficulties in estimating VE and which strains we should put in for next year. And of course, this issue, it has co-administration and its timing with your influenza vaccine, that you do want that 2-week interval between the vaccines. So ideally it'll be COVID, flu, COVID, but depending on which vaccine you're getting and when it becomes available to, you may have to do a bit of schedule juggling. Until we get some data that says, no, you don't need to because there's no problem administering them near each other. But at the moment, that's the regimen. Next one, have I got any more? Oh, yes, sorry, I did show this one. And what we did see was all our other respiratory viruses went away, with the possible exception of rhinovirus. But again, there was a general suppression of viruses. And you can see particularly the biggies like RSV and metapneumovirus and that, we just didn't see them. So while we're still trying to work out exactly what did it, it has been a bit of a fillip for public health interventions and non-pharmaceutical interventions to show that we can achieve control of respiratory viruses. Not that we necessarily want to go into lockdown every winter. Next one, thank you, if I have any more. And Q&A. I'm sorry, I may have used up my time, but.
Thank you so much, Dr. Smith. This is Penny from the program. I just have a few questions that we'd like to ask if we can. So one of them is from Nick, quite quite at the beginning of your presentation, where he asked about, are we going to classify influenza deaths differently given the COVID classification, i.e. someone who dies with COVID have been commonly classified as a COVID death?
Do you mean, I'm not sure when you say, you mean the ones that die within 28 days or something? Is that what you mean? You said when they die with COVID, they're classed as a COVID death, but that.
So yeah, this is a
period of time.
Yep.
Yeah.
Yep. Yes. Yep.
Yes. Yeah, and I thought that's a very good discussion. And I know at NISC there's been a lively discussion about mortality. I mean, one of the problems we've got at the moment with Australia is we don't have a consistent way of reporting and monitoring mortality, and there are people within disease control who are much more involved with that process. So the answer is I don't know. You can ask one of them, but I think it does also emphasise the need for us to get some consistency about how we identify and define a death related to a respiratory viruses, because we have the same issue with RSV deaths as well as with flu. But I'm not in a position to answer that one way, definitely. Yep.
Thank you. And the last one is from Caroline, who asked, can David please comment on the increase in RSV late last year?
Yes, I can comment on it. And I showed that last one, I showed you maybe that I didn't point out in a lot of depth about the increase that we saw today. Thank you, in RSV, and really not much in anything else. And that was seen here and in New South Wales and none of the other jurisdictions. So they have had some activity later. It didn't, and there's been there's been one publication that's come from the TKI people, I think, about the activity in children showing this as well. And it certainly the disappearance coincided with the introduction of public health measures for control of COVID-19. But they came back and we thought maybe for flu particularly it was a closing of the international borders, because we know it's an introduced virus and anyone who came in spent their time in isolation through their incubation period for flu as well, of course. And but it's come back before we've opened the international borders. And I think it needs a much more detailed look at what public health interventions did work, and indeed to compare with what happened in New South Wales and whether there's some characteristics we can look at. But I'm sure that's something the modelers need to do with their calculations of different interventions and when they were put in place or removed. What we do know is that the virus which has appeared here in the second half, we have now done a lot of whole genome sequencing of the viruses in collaboration with our colleagues on the East Coast. We know that in New South Wales, their resurgent season was a single strain of the virus, which obviously came to the population from somewhere. And indeed, it's the same for us. The virus that is occurring after the season is different from the ones that were around at the end of 2019 and the beginning of 2020. And it's unique. It's a single, there's no mixture. All of the viruses, RSVs, are exactly the same. Whereas normally in a season, we get a bit of mixture. And that's true of any age group that we've got. And it's been true for the ones in both the metro and the regional area. So we're doing a more detailed analysis of that as you speak, and just writing up the whole genome sequencing stuff at the moment to show that it's been a single lineage to come in. I think there are a lot of interesting things that you guys, I'm sure, will get onto. Things like, I think there'll be an age shift, because the idea is that during the COVID restrictions, we stopped the circulation. So now we've got a whole stack of kids in the 6 month to 2 year age group who didn't get it last year, when normally a lot of them would have got it last year, and they remain susceptible now, which maybe has contributed to being this a very, very explosive out of season outbreak that we've got now. It's a bit like a sort of pandemic. We've got a new strain occurring in a population with much lower levels of immunity than we would normally have expected in September, October, when normally there would have been a lot of RSV circulating. So that's about all I can say, but it's a huge, and we're really interested in seeing if there are differences in what's happened in the states that didn't have this big comeback as well. So we're doing our bit. We're sequencing lots of things. All it needs is all the public health epidemiologists and mathematical modelers to answer all their difficult questions.
Thank you very much.
Thanks very much, everybody, and thanks very much, David. I really appreciate the time you've given us today for a very informative talk. So we've come to the end of today's session, everybody. I really appreciate your patience with us as we work through the technological issues at the start of the session, but I would say overall we've had a really, really successful session. I'd like to thank Penny and Param and Phil, who's not in the room with us today, for setting up and organizing. We've had a really, really good number of attendees join us. So just a couple of things before we close today's session. One is that if you'd like a certificate, if you'd like to email us, as we sent an email around to immunisation.education@health.wa.gov.au, we'll get a certificate out to you. We'll also be sending an evaluation out for you to complete to all the attendees today, so you can get some feedback on how you felt today's session went. Excellent. Well, thank you very much, everybody.
Can I just say one thing? Sure. Thank you all for listening. I will send through, as you may have noted, I've picked up a couple more typographical errors in the thing, so I will send you a completely updated version, which I presume will be available to people.
We can do that. We can make it available. Thank you, David.
Publish the recording as well.
Yeah. Thanks very much.
Thanks, everybody.
Okay.
Bye.
Bye.